Good evening, everyone, and welcome to the next version of Getting Ready for the Maryland Primary Care Program. Our program tonight is going to be on the Beneficiary and Caregiver Experience. I'm Howard Heft. I'll be your host for the first portion of this program, and then I will turn it over to my colleague, Alice Sawinski-Rice. We'll talk about some of the nuts and bolts, things that we need to do as we move quickly toward the start of the program. And at the end of that period, we'll also entertain whatever questions you might have and hopefully answer them to your satisfaction. So again, it's a great joy to be with you this evening, and when we get started with some of the high-level details that have to do with this portion of the program, which is Beneficiary and Caregiver Experience. So just to recap again, we want to go through, we've been systematically going through the 5 advanced primary care functions. To highlight them, access and continuity was about making sure within practices that patients were empaneled to a provider and to a particular care team, and that there was expanded access for those patients in many different ways. Under care management, it was that those teams for the empaneled patients then were able to risk stratify their patients and, depending on their needs, provide appropriate care management, both short and long term, for those patients. And then for comprehensiveness and care coordination, that there was a coordination of effort and exchange of information between the primary care providers and their high volume, high cost specialists and hospitals, so as to create a patient-centered neighborhood and to continue to make sure that the patients are the care is coordinated. And now, again, these are very high-level concepts. During the program, we'll be getting into many more of the very specific tactics that will help practices affect these high-level concepts. But tonight, we'll just talk about beneficiary and caregiver experience, again, at a high level. So the first portion of this that I wanted to touch on is the Patient Family Advisory Council, or PFAC as it's known. This is something that is extraordinarily helpful for practices, and basically it allows a practice to have an opportunity to get a first-hand consultation with their patients, much the same as they get a first-hand consultation from you, but in a different setting, not a setting in which the patient is in an exam room and in a compromised position in a gown on a table, but in a relaxed setting, and usually represents a representative selection of patients that cut across ages and gender and income levels and races, etc. Those then are convened in a comfortable environment and on a regular basis. And at that time, the patients are solicited for their comments and their suggestions for improving your particular practice. And at the same time, you would provide them with information about things that you're thinking about in terms of improving your practice. Those are all kind of baked together and incorporated into an overall plan that is revisited on a regular basis. So to look at that in a different way, we'll look at the next slide. So this is the practice, and the PFAC will share practice priorities for improvement, remaining transparent, sharing data and outcomes with patients, and patients share their priorities and stay in regular communication. This can be done in an informal way and just a conversation, or it can be done in a more formal way with surveys also. All of this leading to quality improvement. But again, quality improvement through the eyes of the patient, which is much different than quality improvement perhaps through your eyes or other eyes. Next slide. Another portion in a high-level concept is advanced care planning. And advanced care planning is something that should be done for all patients, whether they're young, whether they're old, whether they're healthy or they're sick. And it simply describes, in a broad term, advanced care planning is having a conversation with a patient and saying, in certain circumstances, what is your hope and desire? How would you like me to take care of you? And that can include a variety of different things. It could be a MOLST, which is a signed document that you sign and the patient sign, that would go as far as saying, if I have no reasonable expectation of life and I perhaps die at home, I do not want the rescue squad to try and resuscitate me. And that is really the only document, if a rescue squad is summoned, that would allow the rescue squad to be freed from that responsibility. But it could also include things like advanced directives that the patients could do. They could do those in a written version. They could do them in a digital online version, and the state has those available for patients where they can put their advanced directives in a electronic repository that's available to emergency departments and hospitals so that they would be readily available at a time when they're needed, or they could just simply be written. Anything is better than not having those conversations. And or the patient could simply identify their healthcare proxy, someone who they say, if I can't make decisions for myself, this person can make decisions for myself, for me. Any one of those are important to do, but they should be done with all patients, and particularly with our Medicare beneficiaries. And they're extremely valuable. We know that now in Maryland, only about 30% of our patients overall have any kind of advanced care planning done or any documentation of that. So we have a great deal of distance to go in that regard. Next slide. Along the same lines, integrating self-management for patients. So this is also part of the beneficiary and caregiver experience, so that patients who have high-risk conditions or high-frequency conditions can be encouraged and educated to do self-management for those conditions. So anyone who has something that requires a lot of home care, they or their family can be educated in how to do that home care. Certainly common things like diabetic patients can be educated in how to measure their sugars at home, or how to measure their carb intake and things like that, or patients who have chronic lung disease and how to measure their own peak flows, and on and on. Many things that can be done by the care team to educate patients in self-management. And specifically in this portion of the program, it'll be picking out those conditions where you want to highlight and develop programs to institutionalize the ability to do self-management and train patients in self-management. Next slide. And then last in the high-level discussion here is shared decision-making. And this is something that I think we've talked about a lot for many years, that shared decision-making should always be part of the process with patients, that we should not act paternalistically in every circumstance and tell the patient what they should do, but we should allow them, particularly in situations where there's decisions that can clearly be made, or controversial areas, to give them all the information that's necessary so that they can make their own informed conditions. This could be with a very serious condition where outcomes can be critical. It could be conditions with controversy, or it could simply be a patient who requests, I want to be included in this decision-making process. How deep you go in that is going to be on a case-by-case basis, but every inclination, every opportunity involving patients in the decision-making process is important. And in the next slide, we'll move on to just the basics of remembering why we're doing this all, and it's simply to strengthen primary care in Maryland, to provide the best quality health for all Marylanders. And I would go a step further there and say what we ultimately want to do is provide affordable and accessible, high-quality health care for all Marylanders, and shift your work from the ever-increasing volume demand to a rewards-based, value-based care system, and have your patients avoid unnecessary emergency department and hospital visits. And I emphasize the unnecessary part. Where it's necessary to go to the hospital or necessary to go to the emergency department, they're great places to go. But if their care can be provided in a more convenient, more comfortable, and lower cost venue, we certainly want to do that. And I think at the end of this program, or someplace in the middle, I think we'll be showing the nation, with the work that you do, that Maryland really is a leader in how to do all of these things and do them better. And I remind us all that this is not going to be easy. This is going to be hard work. It's going to take time, and we're all going to have to lean in hard together, put our shoulders to this. But it's important work, and as JFK said, this is something that we intend to win. We're not going to stop just because it's hard. In fact, we do it because it's hard. If it was easy, everyone would do it. Next slide. Just as a reminder, care management, the support for this is found in three ways, and will be sufficient and generous support. and the care management fees, which are paid upfront per beneficiary for a month basis and a quarterly upfront. The performance-based incentives, which are paid annually upfront, and for those practices that are now going to be in Track 2 and those that will move to Track 2, also an increase in your basic E&M code fees by 10%, and then the ability to choose your amount that you want to get prepaid and capitation, all of which will be, I believe, a generous amount of resource. In addition to that, the next slide, for those practices that have selected care transformation organizations, all of the resources that they bring to bear, as well as our coaching team and the things that the Center for Medicare and Medicaid Innovation and their learning system bring to bear to make this difficult process as easy as possible and as guided as possible. Next slide. So I'll stop there. We'll have plenty of time for questions about any of the care delivery requirements or any of the requirements in terms of the application process after Alice finishes with her presentation. And now I'm happy to turn it over to Alice Lewinsky-Rice.
Great. Thank you, Dr. Haft. So as we always do when we start off this administrative section, I'm going to start off by taking a look at the timeline from now until the end of the year, just to give everyone an idea of where we are in relation to the major milestones, and then hone in on what specifically you should be focusing on during the next week or two. So right now we're coming up to the end of October, and at this point everyone should have received a initial preliminary approval either by email, paper mail, or both from CMS. Those communications asked you to fill out 3 forms that were due back to CMS last Friday. And if you haven't turned them in yet, please make sure you get them in later today or tomorrow, because CMS is processing everything this week, and these forms really need to be in for us to move forward with the next phase of the program. CMS is working through everything right now, and the next step once everything is in is to compile the information that's needed to send out letters to the CTOs. These CTO letters will be going out in the next week or so, and those are going to have a list of partner practices for each CTO, as well as the track they've been assigned to and the CTO payment option that the practice selected. Also coming out in the next week or two is the CTO practice arrangement document. And since that's kind of the next big thing that's coming up, we're going to spend a couple of slides going through that, what you can expect from the document, as well as the process for signing and returning it. Looking ahead to early December, both the CTO and the practice participation agreements are going to come out at the same time. And along with the release of that document, there's going to be a second package of information that'll have some final onboarding steps for you to complete before the end of the year. Everything needs to be back into CMS by December 21st. So please make sure that you have all that on your radar and you're ready to turn everything in so that you can start the program come January. Just a quick snapshot of the things that were due in October. So there were 3 forms that were due last Friday. We've covered these in a lot of detail in our last 2 webinars, so if you're still not sure and have questions on how to complete something, take a look at our website. We have the webinar recordings posted there, as well as some additional tips and instructions. But just a quick reminder, the 588 form is for payment setup, and that's a paper form that you need to physically mail into CMS along with a voided check for your banking information. If you've partnered with a CTO, you need to return Form A to let them know how you'll be splitting the care management fees with your CTO. And for 10% of our practices that have been approved for Track 2, you need to return Form B, in which you choose your CPCP option. Form A and Form B can be turned in via email, but the CMS 588 needs to be by paper mail. And just a quick reminder again that everything coming out right now is for preliminary approval only. Everything's still contingent on the completion of a program integrity screening, attribution of 125 Medicare fee-for-service beneficiaries, and also completing all of your requirement documents before the deadlines. In terms of what's coming up in November, December, as I mentioned earlier, we're going to be releasing the CTO arrangement in the next couple weeks. Again, more detail on that in just a second. But we also want to mention that if you're a practice that wasn't already actively using CRISP when you applied for the Maryland Primary Care Program, you might be hearing from CRISP about signing a participation agreement with them. As you might recall, as part of your application, you had to submit a letter of support from CRISP, and that committed you to having a participation agreement in place before the program starts January 1st. So you just need to sign that agreement to close that loop and make sure everything's in place. CRISP has already reached out to the 50 or so practices that still need to sign that arrangement. All those communications should have gone out. And if you haven't heard anything from CRISP, then you're all set and you're ready to go. But we just wanted to mention that just so no one is surprised that they're hearing from CRISP that they need to sign another document. Then looking ahead to December, that's going to be a very busy time. And the biggest thing to keep an eye out for is the practice participation agreement that you're going to sign with CMS. Along with that document, there's going to be a data worksheet that needs to be turned in at the same time. And you'll also be hearing about registering for 2 different portals, both of which are going to help you get access to the data you need to participate in the program. You'll be registering for those portals in December, but you'll have full access to everything once everything kicks off in January. And again, a reminder that everything is due back to CMS December 21st, which is the Friday before the holidays, so make sure you plan accordingly. So now a little bit about the CTO arrangement document that's going to be coming out. This only applies to practices that are partnering with a CTO. So about a quarter of our practices have chosen not to partner, in which case you don't need to worry about this document at all. But for most practices, each practice needs to have a copy of this document executed with their CTO. And there's going to be 3 main parts to this. The arrangement itself is going to be fairly brief, about 2 pages, and it's just going to define the relationship between you and your CTO depending on what option you've chosen. So if the CTO is providing the lead care manager and you're splitting the fees 50-50, that'll be spelled out in the first part of that arrangement. And if not, that will also be mentioned. The second piece is going to be an appendix that spells out the services that the CTO is offering to all of their practices. So CTOs are going to list the services and the staff that they'll be providing to help practices meet each one of those care transformation requirements that we've been talking about on each of these webinars. Ultimately, the practice is the one that's responsible for meeting those care transformation requirements, but the CTO is going to provide certain services in each category. And lastly, there's going to be a BAA that's going to allow you and your CTO to share data for the purposes of the program. CMS is requiring that each practice has one of these in place with their CTO, and everyone needs to keep those on file just in case CMS ever asks to see them. Now just a little bit of heads up on the process that we're going to be implementing to get these documents signed and turned in. We will be sending out far more detailed instructions once the arrangement actually comes out, but just as kind of a heads up, the Program Management Office is going to be sharing the arrangement directly with the CTOs in early November. So you should see that in the next week or so, week or 2. Once the CTOs have that document, they're going to list the services and the staff that they're offering for each payment option and for each track, and they're going to sign their side of the agreement first. Once the CTO portion is done, CTOs are going to take that signed agreement and distribute it to their partner practices. At that point, practices will have the opportunity to review the list of services that the CTO is providing. You get to indicate which of those services you want to take advantage of, and you countersign the agreement. Once the practices have a fully executed version, we're asking that you send a copy both back to your CTO and back to the Program Management Office so that everyone has a copy of the final fully executed arrangement. The drop-dead deadline to submit this is going to be December 21st, same as the CMS deadlines, but we strongly encourage everyone to get these in sooner since December is going to be a very, very busy month, and we want to make sure everything is squared away well before the deadline. So with that, those are all the administrative updates that we have for you tonight. We'll go ahead and take a look at questions next. So if you do have questions, go ahead and type them in on the right-hand side of your screen in the GoToWebinar control panel, and we will read them off as they come in. So our first question is, how often must the PFAC meet? Can feedback be via survey rather than meeting?
So the PFAC should meet at least twice a year. And in the feedback after the face-to-face could be by survey, but there should be, as a PFAC itself, is actually a face-to-face meeting that each practice should have with their patients.
Okay, thank you. Next question. Can more than one practice under the same agency join together to host one PFAC? Can the program be part of a hospital's existing PFAC, or does it need to be unique to the practices?
At this time, it's unique to each practice site. That it would be that practices, that physical locations, patients, that a representative sample is taking of those specific patients related to the delivery of care at that specific site. And I understand the economy of scale, but it is really important that since every site and every practice is different, that it be a sample from the sites and those particular patients and those particular providers in the way that they provide care.
Next question. For practices that choose 30%, will they provide their own care manager, or is this the responsibility of the CTO?
On the 30% option, the practices will have to provide their own care management team.
And is the practice supposed to have a psychiatrist, or is this provided by the CTO?
The practices are required to have behavioral health integration. It does not necessarily need to be a psychiatrist. It could be a psychologist. It could be a licensed clinical social worker who is a behavioral health specialist. It could be under a collaborative care agreement with someone in the office who is a care manager who's specially trained in behavioral health and is looking for those patients who have those behavioral health problems and has a collaborative arrangement agreement with an external psychiatrist. Could be by telebehavioral health or any one of a number of ways in which integration of behavioral health is done. If you have an arrangement with a care transformation organization, they would be responsible for assisting you and making sure that those services are provided, that you have integrated behavioral health.
Thank you. Next question. Are these agreements coming by hard copy mail or email? So the CTO arrangement, we will be emailing out to everybody probably in the next 2 weeks.
Yes, and I would say also the distribution of those between the CTO and the practice back to the CTO and our program management office, all can be done digitally. We'd rather actually not have hard copies of those.
Okay. Next question is, we have multiple practice sites within a large group. We submitted separate 588 and option forms for all practices following the instructions. Several of our practices have been contacted by CMS, and CMS said they didn't receive the 588 forms. Is this a common tracking issue for other practice groups?
So I would say in abundance of overcaution, we, not CMS, but we've been reaching out from our program management office just to assure that practices did meet the deadline and obligations for returning 588. So in some cases, Even though you may have already submitted it, we may have called just to double check on that. Our apologies for any inconvenience in that regard. Again, this is an abundance of caution.
And if you want to confirm that CMS has received all your documents, go ahead and send them an email to marylandmodel@cms.hhs.gov, and they'll be able to confirm whether they have received your paper forms.
Thank you, Alice.
Next question is, in terms of staff listed in the CTO practice arrangement, does the CTO list the total number of staff being deployed to the practice or just the types of staff available?
I think it'll be just the types of staff available.
Thank you. For the PFAC, could we have a Spanish advisory committee and an English advisory committee, thus with different patients? Thus, one given patient would only come in once a year.
I think that would be entirely acceptable. In fact, it's, I think, an admirable thought to do that.
These are all great questions. So if anyone has anything else, please go ahead and type it in.
We'll wait a few minutes. If there are no other questions, we'll give you back the rest of your evening. We'll be continuing this series, again, with some high-level discussion next week about the last of the 5 basic components for advanced primary care. And then we'll have a series of other topical issues to follow on the Thursdays to follow. We'll publish those very soon. Thank you all for your interest, your involvement, and I look forward to working with you as we make a big change here in Maryland. Okay. Seeing no other questions, thank you and have a wonderful night, everyone.